Welcome to the Psychology Talk Podcast. I'm your host, Dr. Scott Hoye. The Psychology Talk Podcast is a unique conversation with experts in the field of mental health from around the globe. Topics include hypnosis and mind-body treatments, ethics and cultural diversity, psychotherapy and psychiatry, emerging treatment modalities, and much, much more. While you're listening, please give us a like and subscribe to the show. It helps us to continue to provide excellent programming. And now, here is the episode. Hello, everyone, and welcome. Today, my guest is Yegnesh Vagdama. He's the Vice President of Clinical Care Services for Autism at Magellan Health. Yagnesh has been with Magellan for over 4 years and in managed care for 5 years, and as a clinician in the field of behavioral analysis for 11 years prior. Yagnesh has over 16 years of experience in ABA, starting off by working directly with individuals on the autism spectrum to directing programs in home schools and community-based settings. Currently, as the Vice President of Autism for Magellan, Yagnesh oversees both the autism and ABA product for Magellan nationally. Today, he's here to talk about autism, and specifically about how autism presents in females, how it manifests in their lives, the differences it presents in the sexes, how they can manage it better, as well as how their loved ones can help them to better cope. Yegnesh, welcome to the show.
Thank you, Dr. Hoye. It's a pleasure to be here today.
Okay, thank you. Well, maybe you can get off, and we can get off to a start by you talking a little bit about yourself and how you got involved in this work in ABA and autism.
Yeah, proudly. Thank you so much. So I've been in the field now actually for over 18 years. And I started when I was an undergrad. And like most psychology students in undergrad, we all thought that we were going to either get a PhD or a PsyD in psychology. And while I was wrapping up my undergraduate degree at the University of California at Irvine, a friend of mine told me, hey, there's an organization that just opened its doors up the street from our university, and they're looking to expand, and they're willing to hire anybody, Yagnesh. And so, why don't you take a look and see what they have going on over there? And I was like, well, what kind of work did they do? And they said, well, it's called applied behavior analysis. And I just had a cursory understanding of ABA from my schooling, what B.F. Skinner had done with operant conditioning. I said, well, let me do a little bit more research and see what this ABA is. And Dr. Hoye, I've been really fortunate in that I come from a line of both educators and scientists, primarily in the medical field. And so I've got my mom on one side is a high school teacher, but she started off in Head Start. And my dad on the other side is a professor of medicine, focusing on oncology within all his research. And I started looking and trying to understand ABA, and from day one, it was this perfect amalgamation that finally fit. And I had gone through my education system not knowing what am I going to do, where am I going to go. And ABA presented the first time this true science. ABA is a hard science where it's measurable and it's observable, but at the same time, it is direct and you have a direct impact, and you get a chance to be hands-on and roll up your sleeves, much in the same way that educators do as well. And so from day one, it just stuck. And I've been in the industry since. And I started off doing direct intervention, working one-on-one, driving to homes, schools, and communities, meeting the individuals, meeting the autistic population where they were at. Worked my way up, got my BCBA, became a supervisor, a clinical director. And while I was in the industry, started to question and ask, well, how can I make a change at a macro level? I've had the opportunity to work one-on-one for such a long time. How can we start to change systems? Because you start to see really the inequities, and I think we can all agree to that, right? Inequities in healthcare exist.
Absolutely.
And what can I do to make noise within the system? And it's now been over 7.5 years now. I've been in managed care and had the opportunity to try to make those kinds of impacts at a whole health system level.
Okay, excellent. Well, how do you think you've made an impact? I mean, you moved over into Magellan to make more of an impact system wide, I take it?
Yeah, I've been really fortunate, Dr. Hoye. What we're really trying to do is change the approach in which we look at autism. And I think, unfortunately, for the longest time in our country, we look at autism through the lens of ABA and ABA services. And it's always the most ubiquitous approach to autism has long been, well, let's get everybody ABA. And while ABA is wonderful and fantastic, as an advocate for my science as well, I'll always advocate for the efficacy of ABA and its correct implementation. But it's important, what we've been able to identify and promote through my time here is we need to have conversations around the whole health of autism and the autistic individual, and not just use ABA for everything, and start to look at comorbid conditions, discrepancies in the diagnostic rates, discrepancies in the rates of the sexes being diagnosed, or different minority groups being diagnosed, or 70 to 80% of individuals with autism have some kind of physical and or behavioral comorbid condition. Are we capturing that? Are we getting individuals into the right level of treatment? So it's a bit of a deconstruction to reconstruct under whole health. Similar in the same way, Dr. Hoye, that we look at cancer. Right? If somebody has cancer, we just don't use a medical treatment and say that's it. You're going to have that medical treatment, chemotherapy, for instance. You're just going to have chemotherapy and that's it. And then you're going to go home and the rest will figure itself out. No, when somebody has cancer, we look at chemotherapy, we look at physical therapy, we look at group therapy, individual therapy, we look at diet, we look at health, we look at exercise. We look at whole health view of cancer.
Right.
And we got to do a better job with the autistic with autistics in doing that as well. We got to find out what is the right treatment package that we need to present.
Well, I know that recently, as far as I think about 2015, when the new DSM came out, there was this urge to subsume Asperger's syndrome into the spectrum. So there's 3 levels of the spectrum, and somebody with what we used to diagnose as Asperger's syndrome is autism spectrum level 1. So, and then the higher the number, the higher, the more difficult and the more deficits they have in interactional communication and self-reflection. And a lot of other things, of course. That's a very cursory example, but how does that help us? How does that spectrum, the 3-point spectrum, do you think that helps with the diagnostic criteria? Because the diagnostic criteria is still pretty open, right? I mean, it's not it's not very vigorous or rigorous yet in being able to diagnose or help a clinician who doesn't have experience with it really see it. I don't know.
Yeah.
If that's something you could address, but how do you is that something you're looking at? Is that something Magellan is looking at? Or what's your take on that?
Yeah, it's a great question. And, one thing that we're able to see, Dr. Hoye, and, is that the diagnostic definition changing has allowed more individuals to come in under that diagnosis and to access a different breadth of services. And so with that, ICD-10 F84 diagnosis of autism, rather than having the PDD-NOS or PDD or Asperger's, now with autism, well, now we can open up new doors and gateways into, well, what kind of services can we get you with this autism diagnosis? And, unfortunately, there have been barriers to accessing things like ABA if you do not have an autism diagnosis. So under the new diagnostic criteria, this now allows more people to come in and say, I have autism. In the past, it was PDD-NOS. In the past, it was Asperger's, but now it is autism.
Okay, excellent. Well, I mean, that does help in that sense. What is the difference of ABA services for people with 1, 2, or 3 spectrum? I mean, this is something maybe we can talk. I'm curious.
Yeah, absolutely. And so it's ABA is individualized. And so that, taking a step back, ABA as a science is based on a single subject design versus a group design. So on the single subject design, we're able to see, is our treatment making an impact for that one particular individual versus let's look at whole systems and let's look at thousands of individuals with ABA, right? You make it challenging. But on the single subject design, what we want to be able to do is tailor our intervention for medical necessity and individual clinical needs. So if we just look at it in a vacuum of severity level of 1, 2, or 3, what we'd want to be able to do is, what is the right level of ABA that's needed given the clinical presentation and the severity level of the individual? Now, that's not to say that somebody with level 1 could not get comprehensive services, which the BACB, with our board, says is 30 to 40 hours a week. It's more so to say, if somebody with level 3, would they need autism and would they need something else? Is there another condition that exists within that is impacting the behaviors or the severity level of that? And I can give an example to that. Mm-hmm. Somebody with level 3 autism who might be more clinically impacted, they may have higher rates of physical aggression. Well, we know that there's strong correlations with physical aggression and GI issues, the gastrointestinal issues. Mm. So with somebody at level 3, what we should be doing, and we're trying to move the industry towards, is, well, let's start getting a GI screening. Let's start getting sleep screenings, because there's sleep disturbances within the autistic population as well. And so can we start to get those kind of additional measures that are into there versus somebody with a severity level 1? Can we start to look at what the long-term trajectory looks like? And should we start to look at talk therapy, group therapy, social skills programming? Mm-hmm. So it's tailoring our ABA programming depending on the severity level.
Okay. Well, maybe we can step back a little bit here and you can help us by defining specifically what autism spectrum disorder is and how to address those individuals.
Sure. So at a definition level, autism or ASD, autism spectrum disorder, refers to a broad range of conditions typically characterized by challenges with social skills, repetitive behaviors, speech, and nonverbal communication. Mm-hmm. And I'm glad that we're having. You would ask the question around, how should we be addressing this population? When I first started in the industry, it was all about autism awareness, and within autism awareness, referring to the population as individuals with autism. Mm-hmm. And one thing that we have started to do a lot more of, and with great humility, is listening to the autistic population and listening to autistics and how they want to be addressed. So something we're hearing and constantly or reading is addressing as autistic and identifying that. And so we want to be able to do is start to talk about it as autism acceptance, not necessarily awareness. Okay. And with acceptance, and acceptance comes from a place of understanding. And that understanding, it takes work. And so understanding them as autistic versus someone with autism.
Gotcha. Yeah. Yeah. And so if someone's undiagnosed who's on the spectrum, I mean, how might they experience their lives, and what are some of the challenges they might have?
It's a wide range. And so this is one of the things that we are constantly trying to have conversations with PCPs, with families, with individuals as well, is how can it manifest itself in physically? So it's important to know, or behaviorally, sorry, it's important to remember, with autism, there's no physical characteristics, right? Not like Down syndrome, for instance, or where you can see physically how somebody is. With autism, it's mentalistic. It's something that's happening internally. And so it's what we want to be able to do is identify at a very early age things like eye contact, things like emotional and social reciprocity. When a parent walks into the room, does the child light up like a typically neurodevelopmental child would do? Are they able to maintain eye contact? Are they able to have motivational operants which will demonstrate that they're interested or passionate about something? Absent of that should be indicators of we should probably talk to our pediatrician around potential concerns. That is there something here in a developmental delay?
Mm-hmm. Okay. And so some of the warning signs, I think you just mentioned, I wouldn't call them warning signs. I call them just indicators, because it is a divergence in experience, right? It's a neurodivergence. I think people are starting to call autism as a sense of neurodivergence, and we're all divergent neurologically. But what are some of those others? You mentioned like eye contact, social interactions, like especially like how does the attachment system work, right? Is that being developed in a way where it's pretty obvious that the child's interacting and trying to get their needs made, like right? Needs met, I think? Is that kind of what you're pointing to?
That's right. That's right, Dr. Hoye. In addition to exactly what you're saying there as well, is the attachment with also repetitive behaviors.
Yeah.
And
Okay.
but I think to what this conversation is here today, repetitive behaviors have oftentimes been the classification or the benchmark for autism. But that benchmark and diagnostic criteria around repetitive behaviors was because it was centered around males.
Right.
Whereas females don't typically have that same repetitive physical interest that boys do.
Okay. So, well, maybe they have a different kind of way of repeating something, right? And that repetitive interest might be a way of finding this, if we're going to use an attachment theory kind of idea, a secure base or a sense of security in oneself. Is, a consistency with something, right? It might manifest differently in females. How might that repetitive behavior manifest differently in females?
It might, yeah. So one thing that we see with research and what leading researchers are indicating within females is females have an ability to mask the diagnosis and to mask the behaviors as compared to what boys do. And so within that masking, that repetitive might be a fixation of conversational topics. It might be or specific interests, things like potentially like a theater or perseverating on a conversation of high interest versus lining up a toy or playing with a string, as an example.
Okay. So repetition in something else. Okay. And that might be more difficult to see, right? It might not look, because you mentioned this masking. And I think that's something that, from my experience of working with people in my own caseload, females with autism, they tend to not know that masking. It's just they do it kind of automatically from what I've heard in my case by case experiences. Can you speak a little bit more about that?
Yeah, absolutely. And so it's one thing that we're seeing is that when compared to boys, in masking from a behavioral perspective, but then what we're seeing is compared to boys that girls will unfortunately also then have a diagnostic rate that's later than boys as well, oftentimes driven by that masking behavior, which is hiding what the physical what the physical traits are, or the physical behaviors are, more so on what the individual is expressing. And so that masking can shield us from identifying autism at an earlier age, which will then unfortunately preclude us from getting individuals into treatment, things like ABA, which can then narrow that gap between the chronological and developmental age, especially as the brain has the greatest plasticity at that young age.
Okay, so ABA early on probably helps better than, say, when they're in their mid-20s or 30s or 40s. Yeah, so
that's
because of that neuroplasticity of childhood. So, and also being able to, I assume, since females tend to be more socially oriented, just as I assume kind of a biological and a social kind of script, helping them to better understand how they fit in with people and what they're actually doing as far as the masking, right? Like having a conversation around that. Well, kind of on that same point, are there any other ways to diagnose or possible the differences between how you diagnose in childhood versus adulthood for males or females?
Yeah, it's one of the challenges that we have is, especially within medical school, right? You hear this from pediatricians routinely, is the diagnostic criteria and the training within the diagnosis. And so, unfortunately, we have a lack of clinicians in our country that feel comfortable diagnosing autism, identifying autism, and then getting individuals into the right place to be diagnosed. So, similar, carrying on with what we're talking about here, Dr. Hoye, when a female will go into a pediatrician's office, there's oftentimes a quote unquote wait and see approach, and say, I see that they are not as social, but it's okay. the stereotypical answer oftentimes is, some girls can just be shy. Let's just give them some time to break out of their shell. Then a parent might say, yeah, my mom was shy, or my sister was a very shy person, or I used to be a very shy person. It's okay. We'll wait and see. But now the challenge then is, if we're not getting in at an early age, we're missing those key years. Now, to your question about the diagnostics for adults and for the younger population, a key element is getting individuals who, if there may be a concern, getting them linked up with the right level of a clinician. And so one thing that we have to start doing is tailoring our clinical models around who has a background and expertise with adults, who has a background and expertise in individuals, and do we have the right battery of exams that can help with that? There's groups, for instance, like ICHOM. I was a part of the International Consortium of Health Outcomes, where we're putting together measures and subsets around, can we start to screen and diagnose autism and comorbid conditions for different age ranges as a means and a mechanism to have a more validated way of capturing what the individual at this particular age is going through.
Okay, so it's a valid way of looking at it for each stage of development, adolescence, pre-adolescence, adulthood, young adulthood, etc. Yeah,
that's correct.
Okay, interesting. Okay, so is that a standardized test, or is it more of an observational kind of case by case version of diagnosis?
I think it's a bit of both, and really what we should be doing is moving into the standardized tests. So there are standardized tests, like for instance, like the ADOS, right, the Autistic Diagnostic Observation Schedule, that will have modules based on the age of the individual, so that we can start to tailor that. And there's even now emerging movements, for instance, around eye gaze and eye movement. And can we start to use eye gaze and eye tracking as a means to diagnose individuals as well at an earlier age? But then for the older age, can we start to use, we would continue to want to use the full battery of exams to see also, are there comorbid conditions? Are there other conditions that are impacting either autism, or is there something else that's impacting the overall behavioral health trajectory?
Okay. Yeah. So I assume that, like, along the spectrum of development, women on the spectrum present with different problems than men, and how does that manifest? Like puberty, for instance, how does that different? How do they cope better with it, or how can they cope? What are your thoughts on that?
So it's something I've also seen when I was in ABA and in clinical practice as well. Is females with autism go through puberty at a younger age. And some studies are saying that they go through puberty at 10 months earlier than the neurotypical population.
Huh.
And I don't know about you, Dr. Hoye. The I as a male and I don't have autism, the I as a male, I remember the challenges and the difficulties when I went through puberty, and not understanding the comings and the goings and the challenges around what's going on. And imagine with somebody with autism and the autistic population and how their brain is then processing it. One thing that researchers are starting to indicate as well is that through early onset of puberty in girls with autism, they have significant psychological, social, physiological, and developmental consequences within that. So there's considerable research has also shown that early puberty in typical developing females is linked to increased risk for depression and anxiety. And we already know that the autistic population already has even higher rates of depression and anxiety. And so it's key that we have to be able to capture if somebody has autism and they're starting to go through puberty, what means and mechanisms and we start to put in place now so that we're capturing these potential comorbid conditions before they get worse.
Okay. Yeah. No, that's very important. There's a lot of challenges, I assume, to just diagnosing autism in females to begin with. But like, how do you suspect this will roll out into the greater, I guess, healthcare system and behavioral healthcare system? I assume that's what you're working on with Magellan.
Yeah, that's right, Dr. Hoye. And within that, what we want to be able to do is curate a medical model. So coming back to that example with cancer, right, where you have that medical model of physical therapists, occupational therapists, the oncologist, the PCP, et cetera, right? Everybody working in concert together with the member at the center within that medical model. We have to do that with autism. And we have to start to curate that medical model so that when somebody is going through puberty, making sure that everybody within that medical model is on the same page. And if we have to bring more in, which the likelihood that we would have to as the individual starts to progress through their lifehood, we would have to do that.
I'm gonna ask you to kind of like fill out that some people in the audience. There's no way I don't know who's listening in, and hopefully it's people who are interested in autism and in general. We have a kind of worldwide audience. Maybe you can extrapolate on just exactly what that medical model is.
Yeah, absolutely. So a medical model takes, if you take the patient, you put them right into the center of a circle. And a medical model takes the entire health system. And how can we curate an entire health system to work together? So you think about, we'll talk here about autism. The autistics will have a pediatrician. They will have a psychologist. They'll have potentially a psychiatrist who's prescribing medication. They might have say they're going through talk therapy. So what is their LMFT or LCSW? The school system, the teacher, the educators, the IEP team, the individualized education plan team, the parent, maybe there's an ABA team. So you can see there's a whole system that is working with the member's best, that individual, that patient's best interest. And so how can we get everybody to work together and to speak together so that what we call an ABA, there's no challenges with the behaviors that are influencing the course or trajectory of the behaviors. And so how can we get everybody to work together?
Okay. So when you're talking about the medical model, it's not like the medical model of mental health. It's more like you're like talking about an integrative medical model for presenting intervention, diagnosis
Correct.
and intervention. Yeah. So it's more like a biopsychosocial model. You're looking at all of those things, right? And how the team can assist the person. Well, that's good. I hope that works. I hope that Magellan can create something that is replicable in other health systems like Kaiser Permanente or whoever else is out there, right, across the country. And also just individual practitioners can be more on the ball with integrating like a psychologist, talking to a medical doctor or a PCP or to a psychiatrist, to you name it, to people working with children in schools and IEPs. I think it's very important. What kind of like going back to females and autism as a topic, what does it look like? What are some of the struggles that females have who are on the spectrum going into young adulthood? Like because that's typically what I've seen in my practice when I've actually had to diagnose people with that. And it does open up, the nice thing about actually hitting upon the right diagnosis with autism is that a light bulb goes off and they're able to look back on why they did things, why they felt so different. And it just kind of like after a while, as it sinks in and there's acceptance of the diagnosis, more so self-acceptance based on understanding that it's a neurological issue. There's a lot more peace. Depression tends to be reduced. Anxiety tends to go down, and more social functioning and interaction. Is more of what we would call autism 1 or Asperger's type people I'm talking about here. But what do you see as like some of the challenges for females who are moving into adulthood with autism?
Yeah, I think when we look at the stereotype of what the autism diagnosis has presented, and again, it's been presented through the lens of a male dominant, to no surprise of anybody, right, with healthcare, is through a homogenous male perspective, which is wildly unfortunate. The research and the indicators, what we've seen also in clinical practice, challenges that you see as individuals start to progress is the brain is a female's brain with autism is actually very similarly mapped to that of a neurotypically developed male's brain, but it's different from a female's brain who's neurotypically developed. And so what you start to see is that widening or that gap between what is your quote unquote typical female population. And so there starts to have a divergence from that. And so that within that divergence, it's not fitting in, the social awkwardness, the social challenges, the lack of friends, the challenges with increased intellectual disability, increased behavioral traits. And so what that also then creates is a widening gap in the diagnostic rate that we continue to see with autism as well. And that's why you often typically see in looking at research across the entire world, whether it's looked at Uganda, the UK, America, females will have a later age of diagnosis than males do. And that is typically, again, because of everything we've just been talking about here.
Okay. So they start to see the differences more, so they become more pronounced for themselves when they reach adulthood?
That's right.
Okay. And that's when they start to look at other possible issues. And well, I'm just, this is speculation, but I assume there's a lot of women who meet the criteria for Asperger's or autism level 1 or 2 or 3 who are not being properly diagnosed, and they tend to be given a lot of medications which don't tend to do anything, and they get the talk therapy, but it's for anxiety or depression or a mood issue. They might be misdiagnosed with bipolar disorder. This is really sad, and I find it's an area that needs to be better addressed in MSW counseling programs, PsyD programs, PhD programs, because we tend to be the ones who do most of the talk therapy. Also psychiatry, right? Like if you can bring psychiatry on board and neuropsychiatry on board, it really needs to be better. There needs to be, you have to have eyes to see it, you have ears to hear it, so to speak. And it's just very sad. I'm kind of I'll get off my soapbox here. It's your soapbox, but I mean, it's just very
Dr.
sad.
Hoye, I'm absolutely there with you how sad it is. And, I'll give another piece of information within that. There's a high rate of anorexia with the autistic diet, within autistic populations. And that's because we just assume that they don't want to eat, and that we're just assuming they're not eating because they're anorexic. No, well, there's high rates of GI issues within autistics as well, and there's selectivity within food, and we know that there's selectivity within food, and we've yet to figure out what the GI issues, what the gut is telling us with autistics. But now you have a population that's just being diagnosed with anorexia and is being misdiagnosed. And again, it's similar to what you're saying here, Dr. Hoye. It's sad, and we're missing the mark so many times with females and autism.
Yeah. Well, maybe you can address this. Are there any particular? You mentioned a few standardized tests that could be readily learned, fairly quickly learned, and then administered by everybody from a social worker to a PhD or a psychiatrist that could help to kind of like focus in better on what the possibilities are for an autistic diagnosis, and then rule things out. Like, so is there anything out there that you would recommend as a specific administration or a test battery?
Yeah, I would absolutely recommend an ADOS as a full test. Okay. And within the ADOS, you're typically looking at anywhere from 6 to 12 hours of an overall assessment that it takes, which is good. It's healthy. I know that sounds like a lot of time. It's going to take multiple visits to see a psychologist or psychiatrist or whomever is going to be implementing it. But we want to be able to get it right. Also, I think what's key here is systematic re-diagnosing, because two things there. One, we want to be able to capture comorbid conditions if they do exist. And two, we want to be able to make sure, do we have the right diagnosis?
Okay. What does an ADAR stand for again?
Yeah, it's an autism diagnostic observation schedule.
Okay.
And so it's in 2016, the University of Washington re-diagnosed 1,500 individuals with autism, and they found that 9% lose their diagnosis over time. An additional 4% should have never been diagnosed in the first place. And so with that, what we want to be able to do is put into place a reevaluation to see, again, is autism the right diagnosis? And if it is, or even if it isn't, well, then what other diagnoses are there? Because clearly there's a concern here. And what is the therapeutic pathway that we can put together and we can start to curate given the changing diagnostics?
Yeah. I mean, that's that's almost 15% of misdiagnosis. That's pretty bad. Yeah. There needs to be a better way to diagnose this, but like you said, it's not like a tumor. It's not a broken arm. It's a very difficult, and it's a very subtle kind of difficult thing to work on, to learn how to diagnose properly. And probably why it's so important to do so earlier on rather than later on, because it's just more of a potential for misdiagnosis. Yeah. Can maybe you can go back a little bit to what ABA therapy is and how does that help people?
Yeah, absolutely. And so ABA stands for Applied Behavior Analysis, and it was initially pioneered through B.F. Skinner through operant conditioning, right? So we know about Pavlov and respondent conditioning, right? Pavlov rang the bell and he got dogs to be able to salivate. Well, B.F. Skinner took a step back and said, well, hold on. If we can get the bell to get a dog to salivate, well, what else can we get the bell to do? And what else can we train individuals to do? And so Skinner's theory is all behaviors are learned and all behaviors can be unlearned. And then Skinner's operant conditioning model kind of lay dormant for a while. And then in the late 80s, Ivar Lovaas out of UCLA picked it back up and started to really use operant conditioning and ABA for autistics. And now there's a tremendous amount of controversy about Lovaas, which I'm sure we can get into another podcast on another day to talk about if we wanted to. But over time, it started to really manifest. And what we see today with ABA, and ABA is systematic environmental manipulation to shape the behavior that you want to see while reducing the socially significant behaviors that which we don't want to be able to see. Mm-hmm. Now, I do want to caveat, because many autistics look at ABA in a negative light. And that's because of the not so favorable work that some behavior analysts or psychologists were doing with ABA in the past with autistic population. And it is wrong. There was a lot of wrong work that was done in the past with autistics with ABA. And they're very vocal. Autistics are very vocal about their discomfort which way that ABA was administered. And so the ABA community has really had to go through a reckoning around listening to autistic population and curating the right ABA models on a natural environment teaching versus the way it was done when I first started, Dr. Hoye. We're going to sit you at a table and we're going to drill over and over and over, and we're going to create this rote robotic individual that we believe in a neurotypical way is the right way to function. And we've since had to really change our practices.
Yeah. Well, that must have been, I'm sure there was a lot of pushback from people who were getting the ABA that informed. I mean, we think as therapists and ABA practitioners, of course, or operant conditioners, that we're shaping someone's behavior, but it's really a dyad, and the individuals also shape our behaviors too. It's kind of what was lacking. It sounds like that was inserted. Oh, well, maybe we should actually get some feedback and be part of. It's not a chicken in a cage or a black box or something. Yeah. Okay. And so, what does that look like? What does ABA look like, maybe for somebody who's an adolescent or an adult versus child?
Sure. So adolescent. So within child, what you want to be able to do is put together potentially a package based on clinical need, of course, but put together a package of you having somebody working direct, and a board certified behavior analyst, somebody with my clinical background, who's curating a program, who's prescribing the number of hours, that's putting together goals that we want to be able to work on, while what are the behaviors that we want to be able to address. So, for instance, things like tantrums or elopement, running out, right? Again, behaviors of social significance. How can we reduce that and replace it with what is it the individual is looking for instead. Are they looking for attention? Are they looking for access? Are they looking to avoid something?
Mm-hmm.
And so you're going to have this large program, anywhere from maybe 15 to 30, 35 hours a week, somebody coming into a home or school or community-based setting and working with the individual. As they start to move into adolescence or even to adulthood, that starts to change. And now what you want to be able to do is create a program where you're promoting generalization. And generalization is actually one of the 7 tenets of ABA, in that we have to constantly be thinking about, because is our treatment modality generalizable to the overall population? So when we take a step out, can the individual start to do different things? So as an example of that, with ABA, what we want to do for young adults is, can we start to look at ABA within vocational programs, social skill programs, how to ride a bus, how to, I don't know if anybody does this anymore, like things like balancing a checkbook, right? So knowing how to understand functioning within an everyday community.
Yeah. Okay. So, and thank you for kind of giving an example of that, so people have a better understanding of what it is and how it works through different stages of life on the spectrum, or for people on the spectrum. Well, do you have any thoughts about how parents or loved ones and industry professionals and community members can advocate for girls or women on the spectrum as they experience physical and emotional challenges?
Listening to them. I think that's the key component there.
Okay.
is listening. It's something that, again, coming back to in our industry of behavior analysis, that we've had to go through this reckoning, Dr. Hoye, is listening to the population, but listening and also observing what the behaviors are. And is what we're doing effective, yes or no? And is what we're doing effective for the individual, or is it effective for us? And are we coming at this from a place of a bias in what we perceive as the right approach? And I can give an example there. For so long, we've been hell-bent on trying to extinguish stereotypic behaviors, or behaviors within what we call stereotypy, things like hand flapping or rocking back and forth or humming, right? Stereotypic type behaviors that we think about with autism.
Mm-hmm.
And in listening to autistic population, as an example here, we've now had to change that and say, that's okay. That's self-regulation. Those are things that feel good. Who are we to tell an autistic what feels good, right? We all have our own inner being. And so what we should be doing as parents and as caregivers, or as advocates within the community, is be allies with autistics. And what is it that what makes them comfortable? What is it that they need? And what is effective? And really, what is beneficial for them in the short term and in the long term?
Okay, excellent. So listening, but that sounds like very good basic interactional behavior for all human beings with each other, rather than projecting opinions on other people. Yeah. Which, unfortunately, I think that there's a lot of diagnostic overshadowing in the mental health business. Everything using a hammer to fix what a screwdriver would be best to fix. That kind of a thing. And then I think we get very jaded and have blinders or blinkers on as health and behavioral health professionals. So, okay. Well, is there anything else that we've left out that you'd like to add, Yegnesh?
Yeah, I'd like to highlight, again, coming back to Dr. Hoye, the comorbid conditions of autism. And for the mental behavioral health practitioners, for the parents, for the allies that are listening, we have to move into a world where we are screening for other conditions. Again, 70 to 80% of autistics have some kind of physical and or behavioral health condition. Mm-hmm. You take sleep, for instance. We know that the secretion of melatonin for neurotypical individuals, it comes in waves, right? It's why we have our REM cycles. It comes and goes throughout the night. But for autistics, it moves rapidly up and down throughout the night, or it plateaus and then it spikes. And so there's tremendous amount of sleep disturbances within autistics. And I don't know about you, Dr. Hoye, when I don't have a good night's rest, I'm a mess the next day.
Oh, yeah. Yeah.
And we imagine now for somebody who's experiencing this over potentially a lifetime. Exactly. And then what that lack of sleep does, and what that lack of sleep does for the behaviors and for the mind. And so sleep is just an example of this, right? going to a sleep specialist and getting a screening for sleep disturbances. And what does it look like for this autistic individual? Mm-hmm. And so we have to start curating packages based on individual needs. And I know that's challenging because there is no playbook that currently exists out there.
Yeah. Yeah.
We're trying to put that together here at Magellan. We're trying hard to rapidly move into that new frontier. Mm-hmm. But as of right now, what I would highly encourage is let's identify comorbid conditions in the autistic population, and what can we do to systematically check off, did I screen for this? Did I screen for that? Do we have a plan in place for this?
Well, you mentioned sleep disorders. Yes, I've experienced that with people in my practice who are autistic. The thing about REM, you mentioned REM and melatonin secretion and whatnot. All those ultradian or short rhythms, biological rhythms, rather than circadian 24-hour clock rhythms. For those of you out in the listening world, they happen to us all day and all night. Right. There's a lot of, Kleitman came up with the basic rest to activity cycle. For those of you who are neuropsychologists, or you remember Kleitman from your intro psychology or grad school. So this happened to us all day long. And so most of us usually get kind of tired around between 1 to 3 in the afternoon. We have those low wave cycles where you just kind of want to, the natural impulse is probably to take a cat nap for most adults, or to kind of daydream and drift and take a pause, right? Or most of us usually insert caffeine at those times. But one of the other things I've also noticed, individual case by case, is that people on the spectrum tend to also get really tired really fast. They don't have a lot of energy, probably because their brains are going through those cycles a lot faster all day long. So it's really difficult for them to kind of modulate themselves in a typical 8-hour day, right? And they wind up crashing and burning sometimes, getting irritable or just tired and decompensating, in some way. I don't know if that makes sense, what I'm saying.
It absolutely does. And so that tiredness, irritability, you take somebody who might be nonverbal, that might then manifest itself into physical aggression, as an example. Yeah. And then we're starting to say, well, they're physically aggressing. And what do we need to do here? Well, we need to put more ABA in there. Versus, if we just got a sleep screening done, maybe they need melatonin. Maybe we just need to get the sleep back on track, and those behaviors start to come down. We see the same... what we call an ABA is parsimony, right? The simplest answer might be the right answer. We see the same thing with the GI as well. Maybe there's constipation. There's high correlation between constipation and nonverbal individuals and severe behaviors, aggression. Well, if you're built up, you don't have a way to communicate that you're built up and that you have something going on internally. Mm-hmm. You're going to potentially lash out or have a physical aggressive behaviors because you have no other way to communicate that you're uncomfortable. And so what you oftentimes see with autistics is, just simple over-the-counter Miralax makes the world of difference because you're now able to relieve yourself of that discomfort.
Yeah. Oh, yeah. And it must have an effect on the ANS, the autonomic nervous system, right? So if somebody's always kind of not sleeping right, there's a lot of cortisol flowing through the system. They have a lot more sympathetic nervous system activity. So they're that kind of fight or flight mode, right? Or freeze sometimes. They don't get much rest and digest, parasympathetic activity mode. So they have a hard time relaxing over time because of this lack of expression. Yeah. So a simple thing like Miralax, that's kind of brilliant. Yeah. I mean, it's a home remedy. I mean, it's brilliant in a very subtle way. So why don't you just give the person a laxative at this point in time and they'll be a lot better. And it relieves their pain. Yeah. Very simple things like that. But, and again, this points to all the systems that are involved in people's functionings that one has to account for.
That's right.
Not just more ABA.
Not just more ABA. That's absolutely right, Dr. Hoye.
Right.
That's right.
Yeah. Not just using a hammer when Miralax would help.
When Miralax would help, exactly.
Yeah. Okay. All right. Well, anything else you'd like to add before we sign off today?
Yeah. Last thing to the to the caregivers, the parents, and the allies who are listening in, you are that individual's greatest advocate. And if you believe that there is a concern, if you believe that there's something there, the chances are there is. So oftentimes we get told, wait and see, let's wait and see, or, I'll wait till the next checkup. Let's advocate now. Time is of the essence. Again, coming back to what you talked about earlier, the brain has the greatest plasticity at the youngest ages. Let's get in now. Let's get the diagnosis as quick as possible so that we can start to bridge those gaps.
Excellent. Yes. Amen to that, as they say. Okay. Well, Yegnesh, thank you so much for being here. Is there a way for people to reach out to you or find out more about you, or maybe for giving a talk somewhere or a Zoom presentation at any point in time or a conference?
Yeah, absolutely. So we have a tremendous amount of great information and resources on MagellanHealth.com. Mm-hmm. And you can also find me on LinkedIn. I believe I'm the only Yagnesh with an autism background on LinkedIn. So it's a good way to find me on there as well.
Okay. Well, maybe the first of many.
Maybe the first. Yeah.
Yeah. Okay. Well, thank you, sir. It's been a pleasure talking to you, and you're welcome to come back anytime.
Appreciate it. Thank you.
Thank you for listening. Did you know the Psychology Talk podcast is all over the World Wide Web? Well, not entirely all over, but we are in social media and we do have a website. Pop over to www.psych-talk.com to find out more about the show. All material is copyright the Psychology Talk podcast. Opinions of our guests are not necessarily those of the host or the show. Material is provided for entertainment and informative purposes only. If you need a mental health professional, please seek one out. Music is provided by the band Serenati.